time to join us on a Friday afternoon and a Friday morning in the States, and we're very happy to have Professor Lipsitch with us, and we'll speak more about him later. So just some housekeeping before we begin. I'd like to request that you please all mute yourself. We have a chat section, so please feel free to post your questions in the chat section. And then finally, Teams has a function where you're able to raise your hands now. So if you have a question and you'd like to ask something via audio, please raise your hand, and you can do so during the question time. So again, just before I start, a request to please mute yourself. So today's webinar is entitled Perspectives, the Epidemiology of COVID-19, and I'll be co-chairing this session with Professor Taryn Young, who is also the Executive Head of the Department of Global Health, as well as the Head of the Division of Epidemiology and Biostatistics and the Director for the Center for Evidence-Based Healthcare. So just an overview about future-proofing, just a reminder for those of you who may not have participated in the first one. We spoke the last time about the World Health Organization predicting 10 biggest threats to global health in 2019, looking at global influenza pandemic, fragile and vulnerable settings, Ebola and high-threat pathogens, and weak primary health care. And we may not have an influenza pandemic, but we have COVID-19 as a pandemic, and this particularly in low and middle-income countries are problematic in terms of the settings being fragile and vulnerable and there being weak primary healthcare settings. So who would have known that less than a year later we would be facing many of these threats? When we thought about the concept of future-proofing public and global health, our question was, how should we rethink public and global health to better prepare us to address the complexities of the rising epidemics? But importantly, we were thinking not just about communicable disease epidemics, but non-communicable disease epidemics. And so our intention is to build a community of practice that comprises of various disciplines and that explores key public health topics of relevance to local context using a futuristic lens whilst considering local realities. And then also to examine contemporary global health issues and to forecast specific challenges that may be faced in years to come. And this was conceptualized in 2019, and here we are in the thick of things in 2020. And importantly, we want to explore the possibility of novel inter- and transdisciplinary solutions and take account of where the world is going. And so we hope to continue such engagements as we seek to start discussions around future-proofing public health. And so today's speakers are Professor Marc Lipsitch, who is from Harvard T.H. Chan School of Public Health. He is a professor of epidemiology in the Department of Epidemiology and Immunology and Infectious Diseases, as well as the director of the Center for Communicable Disease Dynamics. And I do want to thank him for agreeing to be part of this webinar. I read his paper and was intrigued by the paper which is presented on the slide called Defining the Epidemiology of COVID-19 Studies Needed, and sent an email to him to ask whether he would be willing to speak a little bit more about about the content of his study, particularly as we as a country are grappling with issues around testing and also separating testing versus research, but also thinking about how do we use research methodologies or approaches to get a sense of where we find ourselves in our current epidemic. And then second, very pleased to have Professor Hassan Mahomed, who is a professor within our division. He also holds a joint appointment with the Metro Health Services in the Western Cape. And he is, with a team, is leading the case and contact tracing process within our province. And then Dr. Masudah Paleker, who is our public health medicine registrar, who really had a baptism by fire and with Prof. Hassan has been leading the process. So we're looking forward to hearing from them about their experiences. And just to talk about our future webinar, we also have occupational medicine as a component within our department. And on the 18th of June, we'll have Dr. Jack Menkes and some of our occupational medicine registrars who are leading the responses at Tygerberg Hospital talk about occupational medicine COVID-19 response at a large tertiary hospital, reflections and lessons learned. So at this point, I would like to hand over to Professor Lipsitch, and I would also like to hand over to Professor Taryn Young, who will be taking the webinar from this point onwards. Thank you very much, colleagues.
So would you like me to start now?
Yes, Prof. Lipsitch, over to you.
Okay, and I'm not sure, should I share my screen?
Yeah, I think that should be quite easy to get the presentation. Okay, so the presentation is up. Great.
Okay,
over to you.
Can you see it? Okay.
Yes.
Okay, so you're controlling it. Sorry, this is a little new to me.
Okay, no, that's. You can just indicate when the slides must
Okay.
move on, and we will move it on for you.
Okay. Thank you, and thanks for it's an honor to be here, and I'm looking forward to the discussion. Next slide, please. Next slide, please. Ah, I see, I can control it. That's wonderful. Okay, so I will talk actually quite a bit about other people's work that are not from our center, but this is just to give you a sense of the crew that we have had working since beginning of February within our group on COVID topics. It's been quite a large effort. Professor English asked me to speak about this paper that was published with two colleagues who I worked very closely with at CDC in the 2009 H1N1 flu pandemic, and who are now in pharmaceutical companies, but were really some of the real brains behind the response in 2009. This was published on February 19th, which seems eons ago. And this table sort of summarizes what we recommended was some of the crucial types of studies based a lot on our experience with flu. And one of the interesting things is to figure out what relevance the flu experience has. It's been some places relevant and some places not. I should say at the outset that I'm going to rush through some of these slides because I had not fully understood the timing of the talk, but I'm happy to share the whole deck with people and we'll email it when we're done. So please feel free to look at it in more detail, and I'll just skip some of these slides for the reasons of time. Over here are sort of my kind of rough estimates of how well we figured out how to estimate these quantities that we'd like to know in the process of doing better epidemiology. I think figuring out how many cases we have at any given time is turned out to be one of the hardest things, and maybe figuring out what makes people likely to have bad outcomes has turned out to be relatively more straightforward, although it's more descriptive than mechanistic at this point, and some other things sort of in between. The purpose of epidemiology in a pandemic is really to inform and enhance decisions, and this is a graphic that was made by some people from within our state, Massachusetts COVID Command Center, about some of the types of decisions that need to be made, some of the evidence that goes into it, and then which types of evidence need to be local and which types of evidence are really about the biology and the sort of larger picture that we can learn from elsewhere. Again, you can look at that in some detail if you wish. So I think one learning here is that each pandemic is different with its own data quality challenges, and data quality is really the issue with everything here. Our paper originally extrapolated lessons from the H1N1 pandemic of 2009, and we're finding that different virus and testing challenges, the very, very broad spectrum of illness, and especially the different political and institutional context, for example, the sidelining of our major public health agency as a key voice in the US response has really turned this into a very, very different scenario. So I want to talk through each of those topics that are listed on the table of the things that we need to know and what are the challenges. So in 2009, we had proposed with some other co-authors how to maintain surveillance when there are too many cases to count as the numbers balloon and it's no longer possible. And what we suggested there really is turning out not to be very applicable here because of a few things. What we had suggested there was combining syndromic surveillance, where you count the number of illnesses with certain characteristics, with targeted viral testing of a subset of those illnesses. And that's turning out to be not the best way to go in this pandemic, I think, because of the incredibly variable spectrum of severity, which precludes the surveillance of one type of case as an indicator. And then this is exacerbated by the fact that regular healthcare in many cases is breaking down. People are not going to get healthcare for mild illness, and so the testing can't be done in a way that's sort of reflective of continuing disease activity. And then I'll mention again later the hyper-politicization. The politics, at least in our country, are unlike anything we've ever seen. I know you're no strangers to that with epidemics, but this is something new for us, at least in terms of its scale. So this is what we suggested in the 2009 paper, but it really is turning out not to work. So I'll pass that. One of the things we figured out, and this is work that we did, but many people have figured this out, is that a challenge here is that it takes a long time between when a person gets sick and when a person gets infected and when they become severe enough to be hospitalized or enter the intensive care unit. And so these are lagging indicators, lagged by 3 to 4 weeks in some cases, relative to the time of infection. That means that if you're doing control based on these indicators, you are necessarily handicapped by the fact that you're looking at that you're controlling the epidemic the consequences 3 or 4 weeks hence, or equivalently, you're looking at a lagged indicator by 3 or 4 weeks. You can see that very clearly in the data here from Wuhan that we compiled from publicly available sources, where we were interested in the potential impact of a similar sized wave of the pandemic on U.S. intensive care. But what we really noticed was that from the date of the lockdown here on the 23rd of January, it was about a 4-week delay until the peak of cases. Some of that was due to the lockdown becoming more effective over time, but a lot of that was due to the fact that it just takes people a long time. So while the goal of one important goal of control measures is to protect the healthcare system itself is a lagging indicator, and so you ideally need some less lagged indicators, and I think nobody has found the perfect answer to that, or even a very great answer to that, but it is a challenge. Another challenge is representativeness, and we've seen that with the number of surveys that have been done, both of serology and of virology, that even if you start with a representative sample, not everybody wants to do it because it's unpleasant enough to get an NP swab or a blood draw that many will decline. And so you have selection effects, even if you start with a random sample. And many surveys have started with quite non-random samples, like people on a street corner, who are by definition those who are not social distancing as much as a typical person. And this has led to very vocal criticism of individual studies, like the Santa Clara study, that got a lot of notoriety in the United States and California, where sampling approaches were among the many things that were criticized, that it was not a representative cross-section. And so if you don't know who you're sampling, you can't really extrapolate to the population. I mentioned politicization. I can't resist just dwelling on this graph for a minute. This is data that were published by the state of Georgia's Department of Public Health, and it looks like a declining number of cases. If you look more carefully, it's probably hard to see on the webinar, the order of the x-axis is not time order, but is rather the order that makes it look like it's a declining number of cases. So in fact, the days are reshuffled in order to make it look like it's declining. And the order of the counties is also reshuffled to make it look like the leftmost bar is highest. So this is the kind of data manipulation that's happening at state levels in the United States. There are other kinds of monkey business going on that I won't even dwell on, but it's just the level of trying to pretend something is happening when it's not is really quite amazing. So what can we do, and what can places that can learn lessons from missteps that the U.S. and other places have had do to improve case counting? I think the most important thing is representative populations, is to use representative populations starting from a probability sample, maybe from a statistical agency or a DSS perhaps. Other sort of semi-random samples include virus testing of delivering mothers and infant dried blood spots to get maternal serology. That's a somewhat more representative because giving birth is not is quite a common activity across society. For when healthcare delivery is still functioning, testing those who come in for non-COVID reasons is one option. But we still have a lot of challenges here. This is an example of an early analysis by some colleagues of mine at Harvard and groups in New York City, looking at maternal virus prevalence in the random screening of all women, or the comprehensive screening of all women who come in to deliver babies in New York City. Those who know New York City will recognize this as Manhattan. This is Queens and Brooklyn and the Bronx, and Manhattan is the richest and as you see on this side, the most socially distanced part of the city. You see the largest declines in commuting movements in Manhattan and the lowest prevalence of virus among delivering mothers. And in the other parts of the city, this perfectly tracks the decline in commuting movements. So places with more social distancing have had lower maternal virus prevalence. A next question is about the risk factors and timing of transmission. This is also challenging for a different set of reasons. The variable symptom profile makes contact tracing very hard to do, and so it's hard to tell who transmits. The common symptoms and the severe symptoms and the less common symptoms have been delineated, but as you can see, many of them are quite nonspecific. And the less common symptoms, like loss of taste or smell, are the ones that are more distinctive to this infection, but they only happen in a rare number of people. One thing we have learned, and this is work from the group in Hong Kong and in collaboration with a Chinese group, is that pre-symptomatic transmission is relatively common. Someone is asking for control of the slides. I don't know. And so they analyzed a number of case pairs and the timing of onset of symptoms in the index and recipient case. And based on that and the timing of contact, they inferred that pre-symptomatic transmission was about some 40% or more of total transmission. So that's and they note some special factors due to the population they were studying, but that is an impressive proportion. That probably relates to something that they also found, and again, this was work we were not involved in, but very important, and I want to mention it, is that the timing of shedding seems to be highest, viral shedding seems to be highest at the beginning of infection, and maybe even more before symptom onset. They don't have data from before symptom onset, but there's clearly a decline in the viral load as inversely measured by the CT value over time in individuals. The risk factors for transmission are still poorly defined, especially the risk factor, one of the most important risk factors that we would be interested in for decisions like school openings, like age. It may be very highly contextual, But this is so there's really very limited data at the moment. This is some of the most best data I think that exist, which is the proportion of contacts infected as a function of the age of the source patient. And you can see that that in the Netherlands data, there's no transmission from individuals below 20, below 19. I suspect that would not hold up if you made a larger sample, but this is one bit of evidence in support of children not being important transmitters. They do get infected, but they don't seem to transmit as much, I would say, is the current very tentative understanding. What can we do to understand all of this better? Our group has been really advocating the use of social seroepidemiology. And in the US, and probably not only in the US, it's very clear that poverty and race are associated with bad outcomes and with infection risk, but we don't have a detailed understanding of why. We don't fully understand. We think it's probably both infection risk and the probability of bad outcome given infection, perhaps due to concentrations of comorbidities. But also infection risk, probably because social distancing is a luxury, as one physician has put it in the US. It's easier to do if you have more space and an occupation that allows you to work from home, and you don't depend on public transport. So the idea would be to mimic something like this very old study that I found in our library, someone's PhD thesis from 70 years ago, 90 years ago, where they looked at household crowding and diphtheria seroprevalence, and found that more crowded homes had more diphtheria. I think in the seroepidemiology studies that we do now, there's a chance to really investigate mechanistically what are the exposures that people have that make poverty a risk factor, because saying poverty is not really, we're not going to fix poverty in this epidemic, but we might fix some of the specific mechanisms by which poverty leads to bad outcomes and infection. It's been suggested by a group in Spain that the local patterns probably are going to vary a lot based on co-residence patterns. So this is a estimate of a form of vulnerability that depends on the co-residence of young and old people together. And South Africa is right in the middle here, as you can see, as you maybe can't see, but that's what the arrow is. So next I want to talk about severity briefly. And I think you're all well aware that the biggest determinant of case fatality risk among symptomatic people is age, and that it's a very dramatic increase from well under 1% to several percent in the oldest age groups, and that the risk of symptomatic infection also seems to increase with age. Probably the most comprehensive risk factor study that I'm aware of is from the Open Safely Collaborative in the UK, and you won't be able to read this on the webinar, but the biggest determinants are, again, age, and then followed by obesity, ethnic group, with whites being the lowest risk in the UK, deprivation, so social class, and then a range of medical conditions. In the 2009, we thought about it in terms of a pyramid with deaths as the highest level of severity, and then declining levels of severity down to serological infection. And we've been trying in our group to build models that sort of relate these different levels. The biggest challenge is figuring out the serological base, this lowest level of who actually got infected and made an antibody response. There have been a number of serologic studies, all of them subject to significant caveats, although the UK and Spain and some other countries are beginning to do proper random samples that overcome some of these caveats. But But the lesson so far, I think, is that seroepidemiology shows enormous geographic variation, that part of the story of high disease rates in certain groups are high infection rates. In this study in Chelsea, I don't seem to have a cursor, but the study in Chelsea, Massachusetts was a small study and not a representative study, but it showed that the finding of large numbers of cases of severe disease in hospital reflected high underlying infection rates. Again, there's been a lot of criticism of the methods, especially the problem that in a low prevalence population, a slight bit of non-specificity in the test leads to a very low, very poor positive predictive value. That if you find 3% infected, you don't know if that's because you're only 97% specific or because 3% are actually infected, and that's a real problem at the low levels. As infection rates grow, that will become less of an issue. The estimate of the infection fatality rate at the moment, meaning the per serologic infection rather than per detected case, is I can't actually see what the number is because it's something's covering it that I can't move on my screen, but maybe you can see it. But the estimates range almost all below 1% and almost all above 0.5%. And I apologize, I can't actually see the numbers in the estimate. I think one thing we've learned is that there are undetected deaths and collateral damage. That is, deaths do not all get classified as COVID for two reasons. One is probably the testing is not complete, even on those who would test positive if they were tested. Actually, three reasons. The second is that that like with flu, there are probably a number of deaths that are due to COVID, but do not register as a viral death, but register as consequences like heart attacks, strokes, etc., and may not have been tested even if they were suspected. And then the third piece is the collateral damage, as the healthcare system is less effective in treating everyone. And so all-cause mortality is an important indicator. And this has been a partnership by a former student of ours, Dan Weinberger, now at Yale and the Washington Post. So I think there are some opportunities to study severity. I'm going to skip the parts about seroprotection because that takes too long to explain. But we have a preprint about that led by Rebecca Kahn. I think there is some evidence of seasonality. And the sort of general consensus from our work on other beta coronaviruses and from other people's work on the data from COVID-19 to date is that there probably is a seasonal component, but that in even temperate climates, it's not going to be enough to bring transmission down below the reproduction number threshold. It might be around 20% between the highest transmission in the winter and the lowest transmission in the summer. So I'm over 20 minutes, so I'll just state the conclusions that I think we've learned a lot about the basic properties. This is a hard virus to control because of the variable clinical spectrum and high infectiousness among not very sick early infections. That social factors clearly affect the infection risk and outcome. We need a lot more information on this, and this is clearly going to be locally specific and not something one can generalize across all parts of the world. Some key issues we did not highlight in our February article, like seasonality and seroprotection, the question of whether immunity is very effective, are very important. A key challenge has been representativeness of sampling. And I think there are many opportunities to compare across countries and regions to understand which risk predictors, because confounding is often a local phenomenon, that risk factors cluster in different ways in different places. It may be that we can learn more as we see what sorts of patterns are repeated across the world. So I will stop there, and thank you for indulging my slight overreach.
Well, thank you very much, Prof. Lipsitch, for the very comprehensive presentation and through the process also reminding us of the various key concepts within epidemiology. How we will move forward is that we're not going to take any questions or comments now. We're going to move straight to the next presentation. That would be by Professor Mohammed and by Masudah. And then following that presentation, we will then take questions and comments as it relates to both presentations. So I'm going to hand over to Hassan and Masudah.
Hi, thanks, Taryn. Thanks, Renee and Taryn, for this opportunity to talk. And thanks, Marc, for your excellent presentation. I think just to say at the start that this presentation is on behalf of a big team of people across different organizations and different universities. So we've all sort of contributed to the data or the messages that are coming through here. I think just to set the scene and building on to what Marc has said, we are all presented with a lot of data through various reports, through the media, World Health Organization, etc. Number of cases, number of deaths, number of hospitalizations, number of tests. A lot of these are derived from routine data systems. And we just want to talk a bit about what's behind those numbers, how do we view them. It's not to demodelize you, it's more to develop a sense of critical thinking. And we all know that critical thinking is something that needs to be strengthened in the world today, with fake news abounding, with a lot of misinformation that's around. And this is really just part of that effort. And as we move forward, given that we want to think about this as future-proofing, it's encouraging that sense of how do we understand data, what should we take into account, what should we think about, and just to enable us to ask questions when anyone presents a set of data, whether it be in the scientific literature, be it in official reports of organizations, or be it in the media. We all need to have a better understanding of that, and that's really what our presentation is about. So Masudah is going to present it. So over to you, Masudah.
Thanks, Hassan. So I'm going to start off with a brief description of the current global situation before moving on to the South African or Western Cape context. So as we know, COVID-19 was declared a global pandemic on the 11th of March, and the number of new cases has been steadily increasing globally over the past few months, with South Africa seeing its first case on the 5th of March. As of today, this morning, it had over 19,000 confirmed cases. So currently, the Americas have the highest reported number of cases, and Europe has the highest reported number of deaths. The next few slides are from the WHO website, from the situation report. This is the WHO situation report map of new cases reported 1 month ago. So this was between the 15th and the 20th of April. So as you can see, North America, Europe, Brazil, and parts of the Middle East were reporting the higher numbers of over 10,000 new cases in the preceding 7 days. There are numbers in Africa, but far fewer, with about 6 countries not having reported any new cases at that point. And then fast forwarding to a month later, we have the current map with the US having over 100,000 new cases in the last week. And most countries on the African continent are reporting under 1,000 new cases in the last 7 days. Between these two maps, although the scale is quite different, the relative number of cases reported per country has more or less stayed the same, or at least per region, with Africa still reporting fewer cases. And I think this just goes to show that we do need to look critically at the data received and assess whether it is actually comparable to other parts of the world. And we can do this by comparing testing strategies and also methods of surveillance used in the different regions. So if we look at the number of confirmed cases over time, Africa is the part on top of here that's shaded in green, and it is increasing, but you can see it's not increasing as the same scale as the other regions. Reasons could be, the first more unlikely reasons, that there are actually fewer cases. But it's actually more likely to be that lower numbers are reported and we may not be seeing the true picture in the African region. And this could be due to a number of reasons: resource constraints, inaccessibility to health facilities, health education, so patients won't know when or why they need to get tested for COVID, and then also methods of surveillance used in these countries and whether active case finding is a feasible option in those regions. In order to track an epidemic, we epidemiologists make use of indicators, and Prof. Lipsitch has mentioned quite a few of them. I'm going to run through a few of them in the next few slides. So what indicators do, it provides interested parties with a snapshot of the actual current situation. It allows managers and decision makers to know where and how to focus and inform their strategy and policy. A good indicator should be clear and concise, and it should focus on a single issue that provides the relevant information on a situation. It should be feasible in collecting meaningful and credible data, and they should actually measure what they are claiming to measure. If an indicator if it's not feasible to collect data for an indicator, it will have little or no utility. So this is why we need to be critical when looking at data. It is important to note that no country knows, like Prof. Lipsitch also mentioned, no country knows the true number of people infected with COVID-19. And what we do know is the number of cases reported in those who have been tested, which is not equal to the number of people who are actually infected. This number is much higher. So a few of the indicators that we do use. So firstly, number of tests. Countries have reported this in different ways. They can report on number of tests done in total, the number of people tested, which would be different because many people would have retested to assess recovery, and then also the number of tests per 1,000 people. So when using a denominator, it allows us to calculate rates and then also define an at-risk population of interest in order for us to get more information. The pros of this indicator is that we can check positivity rates based on the numbers tested and numbers reported. And then we can also assess our testing strategy when focusing on vulnerable at-risk groups. The downside of this is that it's not a true reflection of disease progression, and it will fluctuate based on the time in the epidemic in the region. So for example, early on in the epidemic in South Africa, we had more strict testing criteria early on, and therefore fewer tests would have been done as a result. And then maybe later on in the epidemic, we may need to preserve resources. And so fewer tests will then be done on the people. Also, another thing to note is that the private sector may be more lenient and therefore testing criteria and therefore have higher testing rates. So we can't always use number of tests as a true reflection of what's going on with the disease. In terms of reported number of cases, this will always be an underestimation, and this will be because of the testing strategy in the region. Not everyone is tested, and then also you would get asymptomatic cases or those with mild disease who would not necessarily go for testing. Of the tests done, however, one can get an idea of positivity rate and assess case finding strategies if there are any. And although it is inaccurate, it can still provide us with an idea as to the progression and spread of the virus in the different areas. And it can assist us in directing our efforts to more vulnerable populations if we use our sub-district level data. So just to give you a picture of the current situation, this is a diagram adapted from a colleague, Dr. D.Phil. It illustrates the number of cases that we are actually able to do contact tracing on, which is a small subset of the known cases that have actually tested positive. And this in itself is a fraction of the actual number of cases that are infected in the region. So as a result of this, we are only really contacting a small proportion of our high-risk cases in the province, with many remaining undiagnosed and only being diagnosed on hospitalization or even post-mortem. So another indicator that can be used is admission to hospital, and this also only forms a subset of cases and will depend on disease severity, access to hospitals or healthcare services, and also health-seeking behavior, among other things. It does provide us with information on disease burden, and it can also assist us in planning and prioritizing hospital resources for the coming weeks. It's a more robust way of measuring the epidemic, but it does depend on the clinical suspicion of COVID in the case in terms of the clinical presentation to the health facility. So the number of deaths can be used to calculate mortality rates, but again, the data needs to be accurate in order to get an accurate number. Initially, what we were finding in the Western Cape is that deaths were mostly occurring with inpatients in hospital with severe disease, and they were known to us. But as community transmission increases, the diagnosis of COVID is being made for the first time on hospital admission or even post-mortem with a positive lab result. We also have deaths that may not be counted as COVID-related deaths, and this could also include deaths occurring at home or suspected COVID deaths but unconfirmed at the time of death. Someone's not muted. Can everyone just make sure they're muted? Thanks. So the excess all-cause mortality, I think Prof. Lipsitch also mentioned this. I feel like it's a useful tool, it's a useful indicator to use, but in our setting, it might not necessarily be as valuable. For example, under our regulations under the Disaster Management Act, there's been a ban on alcohol and restriction of movement, and this data will therefore be skewed. Our emergency units are already seeing far fewer trauma cases than other years, and as a result, our mortality data this year will not be directly comparable to other years, so it may not be as useful as it would be in certain parts of Europe or the US, for example. And then in terms of recoveries, we know that about 98% of all cases of COVID will recover, and this reporting can be roughly automated to 14 days after mild symptoms, 14 days after diagnosis if asymptomatic, or 14 days from discharge of hospital if there's severe illness. But since we aren't reporting all our cases, we also aren't reporting all our recoveries. The data we gather on patients to apply these indicators is only as good as our collection tools and resources. So in an ideal world, the patient flows through a system and the flow of information would look something like this. The patient becomes symptomatic, they are aware of their ill health and thus visit a health facility. The patient gets triaged appropriately with strict IPC, they get screened and tested, and if the patient is a person under investigation, they're isolated at home from the time of suspicion of the diagnosis. The result is available from the lab without delay, and the patient has access to the results immediately. They're isolated and their contacts are quarantined and monitored. However, realistically, and in the current situation, this isn't happening, and this data that we gather from this is therefore not accurate. And for the following reasons. So firstly, when a patient becomes symptomatic, depending on their health-seeking behavior and level of education, they may not perceive their symptoms to be of ill health. They may have prior medical history, prior illnesses that may perceive their symptoms to be of a result of another illness other than COVID. And they won't necessarily seek help because of that. The patient may then visit the health facility and may be triaged into a COVID-19 area or not. If they are regular revolving door patients, for example, known mental health patients or patients with a known chronic lung disease, they may be sent to an area that they are regularly treated in and not screened for COVID. Or they may arrive with severe illness by ambulance and no known medical history. The testing strategy has also changed a few times based on the national person under investigation criteria. So initially, we were doing tests only on imported cases or those in close contact with imported cases, because those were the cases that we were getting in the beginning of the epidemic. However, community transmission was already in effect, but our testing criteria had not changed at that time. And I feel like this resulted in many missed cases in the early stages of our community transmission in the country and especially in our province. Testing is also dependent on the index of suspicion that the healthcare worker has that the patient is a case. And then lastly, the test in itself has its own challenges. Depending on the site and the quality of the sampling, the sensitivity of the test varies, around 63% for a nasal swab and only 32% for a throat swab. And then next, in terms of our laboratory results, there are delays in testing, delays in reporting, and reporting errors, all of which hinder timeous and accurate data reporting. Our lab capacity has been stretched thin in terms of both actual machine time and capacity to conduct tests, and then also the consumable resources such as reagents that are utilized in testing. We are therefore reporting less cases daily due to the lab backlog and not necessarily because we have fewer cases. A consequence of the delays in receiving the results changes the testing behavior of people. So people might realize tests are they're only being notified of their positive results a week later and then may not want to get tested as a result of that. And then also the testing strategy changes as a result of reduced lab capacity. So tests would therefore need to be reserved for those who need it. So maybe hospitalized patients or vulnerable groups, other enclosed populations. So this kind of thing changes the strategy, but also changes patient behavior. Another indicator we have used is looking at the number of close contacts per case, and then also the number that our teams have successfully managed to trace. The challenge with looking at this number is, firstly, it's dependent on all of these prior elements described to have gone absolutely smooth in order for us to get to this point. It is also dependent on the case providing us with accurate data on their close contacts. And then it's also dependent on us having accurate phone numbers and other details about each of those contacts in order to trace them. Early on in the epidemic, with the imported cases alone, we were easily able to get hold of the close contacts. The airline contacts were the ones that proved to be the bigger challenge. Now, firstly, contacting all of our cases, and then secondly, tracing their household contacts or close contacts has proven to be difficult. With the increasing community spread, the virus is infiltrating much more densely populated areas, with in some cases up to 10 people occupying a single room in an informal house. And even if our tracing teams are able to trace these contacts, the next difficulty is their inability to quarantine adequately. So just to talk a bit about surveillance, the accuracy of reporting depends on the type and strength of surveillance systems that are in place in the region. There are pros and cons to both active and passive surveillance. So firstly, with active surveillance, when we are actively looking for our cases, actively testing large numbers, it would increase our case finding rate. Our asymptomatic cases will be tested and higher numbers will be reported. However, the downside of this is that the nature of the PCR test is that because it detects viral protein, it could test positive in cases that may have recovered and are no longer infectious. And this would result in isolation of cases that may no longer it. Other factors that need to be considered with active surveillance is the value of knowing whether certain populations are positive or not. For example, if you are a known case and you suspect that you have COVID, but you have mild symptoms or asymptomatic, what is the true value of testing you other than for reporting purposes? What is the true value of testing households? Should they not all automatically just be considered positive and self-isolate if they are by the means? These are the questions we need to be asking ourselves. And then in terms of passive surveillance, where you wait for cases to make contact with the health system to be tested positive, here we won't be reporting on all of the cases if we use a purely passive method of surveillance. So in the Western Cape, we have used a combination of the two in our strategy, and we've done both active and passive surveillance. In terms of the active surveillance, we've done this in workplaces, for example, which yielded many positive results. But then our active surveillance in the community screening and testing yielded far fewer results. The reason for that may be that we tested in the community too early on in the epidemic. To inform our testing going forward, we need to recognize the value of testing in certain populations and reserve testing to where it is required and where it will be of actual operational value. So to limited enclosed populations, hospitalizations, and certain vulnerable groups, and not be testing those with mild illness or asymptomatic, much like many of the other countries have led to. So to summarize, a combination of types of surveillance is used in tracking COVID-19. The types of surveillance will affect the indicators used in reporting. These indicators need to be used appropriately depending on the data source and availability. And most importantly, we need to have a critical mindset when looking at the data and looking at all these numbers that are being reported on for the countries globally. Thank you.
Thank you, Masudah. Thanks for your presentation. I think, again, we want to remind people of the challenges of the routine data that's made available. I think what Masudah has presented clearly suggests that a lot of the data that we do see is likely an underestimation of the true size of the epidemic that we're experiencing, and for all the good reasons that are mentioned. I think this has quite important implications for strategy that one follows. It's clear that in a resource-constrained environment, a strong testing strategy, or a strategy that's strongly focused on testing, is not appropriate. That's only appropriate in a well-resourced setting. Rather, the focus should be much more on measures such as lockdown and behavior change if one wants to achieve containment and to do containment. Of course, in the early stages, when there are a few cases, a strong track and trace and test strategy is quite important. But as an epidemic evolves, as it becomes more entrenched, dependency on testing becomes less useful, and it certainly doesn't give one a true picture. So I think with those words, I'm going to stop and then hand back to the chair. Thanks very much.
Okay. Thanks very much, Masudah and Hassan, for that comprehensive presentation and reminding us of what the ideal situation can be, and of course all the challenges that we face. We now have an opportunity for questions or comments, and these could be directed either at Prof. Lipsitch in the first presentation, or any questions or comments for Hassan or Masudah linked to the second presentation. So you can either indicate by clicking on the hand, then I can hand over to you to actually verbally put your comment forward, or you are welcome to also use the chat to put a comment in there.
Hi, Taryn. I see there's a question from Vincent in the chat line, which I'll comment on. When is testing needed in those people called essential, since a large number of infected people are not symptomatic? So, I mean, I think it's, of course, challenging. Again, the strategy that we're trying to use is to focus on people at higher risk, but that's for a different reason. It's not for containment, but really to look at how we can minimize mortality and morbidity. But there are groups like health workers, for example, who, because they are working in a health setting, pose a risk to people who are at high risk. So it would be important to try and determine whether people are positive in those settings. So it's thinking strategically about what is the goal of testing and what you're hoping to achieve. We accept that there are many people who are not symptomatic. But if we had to apply a testing strategy to find everybody who's not symptomatic, we, in a resource-constrained setting, would be overwhelmed. And in fact, it would defeat the object of testing, because we would inevitably have delays in getting results. And that would defeat the object of trying to contain, because one actually needs a rapid response to any positive case in order to, maximize the value of testing. So I think those are some of the challenges that there may be with testing too broadly. but certainly there are specific groups where testing is useful, and health workers and other essential workers may also be appropriate. But again, it needs to be linked to a rapid response time by laboratories in order for us to be effective. Thanks.
Thanks, Hassan. So there's another question linked to the testing approach, and in this case, asking any of the speakers to comment on the limitations that's placed on our efforts by the inherent properties of the test linked to validity, specificity, and sensitivity. So I want to check either Hassan or Prof. Lipsitch whether you would like to respond to that question.
I'd be happy to take part of it at least. I think
Thanks.
sorry, I'm going to move to a quieter place. I think that if we're talking about virus testing, it depends a bit on the type of test, but PCRs actually are very highly sensitive and highly specific if there's virus present. And PCR testing is not what's known as analytic sensitivity, meaning does the test detect virus if it's there, but sort of practical sensitivity, given that a swab doesn't always get virus. And so that's where the loss of sensitivity tends to happen, as I understand it. The second thing to say, and so I think that one limitation there is that that's what leads to the so-called reinfection cases that have been observed, where people test negative and then test positive again. That seems to be an aspect of the test just not picking it up. The other thing to say is that some of the newer technologies that are emerging, their paper strip antigen tests and other things, tend to be less sensitive, but some colleagues, and I agree with them, have argued that this is possibly okay because they're low sensitivity precisely when the viral load is low. And so if you're testing for trying to figure out contagion, at least, then you may not mind if low viral load is missed and be more concerned about missing high viral load. If you're doing it for hospital diagnosis or for treatment decisions, then of course that's a different issue. So I think, as was said before, strategically thinking about the uses of testing is essential because the test characteristics you need are different. I'd also just like to briefly say I thought the discussion of contact tracing and its limitations was really interesting. I've been sort of making a similar argument, even in a sort of middle resourced place like the United States. And I say that advisedly, given that we have sort of done a terrible job of building up our resources for testing. So we are not in the top category, despite, because of our national policies. We're in the middle category of resources for testing. But I've been making a similar case, and I think there's a lot of faith in places that aren't that much better at testing, perhaps, than the one that you're describing, like some states in the United States, where I think there's a bit of a hope and faith and even magical thinking that test and trace will be the ingredient that makes it possible to reopen society without viral spread. I think that's mostly undue optimism. So it's refreshing to hear a similar argument being made. I think the challenge is that the alternative strategies are also quite undesirable because of the economic and social impact. So, but it's useful to hear another perspective because I think there's a lot of over-optimism in our country, at least. Over.
Thanks, Prof. Lipsitch. So there's I think maybe let me go first. I'm going to ask Hassan to look at the next question, which is, what would a rapid response involve, and is that still possible in South Africa?
So the second question, I would say, in selected areas, and if you look at a country like South Africa, there's a lot of diversity in where we are seeing cases, and it still may be useful for rural areas, small towns where they haven't had cases to have a rapid response. And the challenge is that the laboratories are quite centralized. So, for example, in the Western Cape, there are 3 laboratories. The Cape Metro has huge numbers of cases, and the laboratories are busy with processing those. And those from the rural towns, when they want to access testing resources, their samples go to the same laboratories. So we'll have to have a system of prioritization for those samples, and I think if there's a rapid turnaround, and if that's possible for those areas where there's still very few cases, I think it's still relevant. And a rapid response involves simply suspecting someone has the disease, making sure that they isolate immediately, sending the test off to the lab, getting confirmation, and then if it's positive, making sure that the close contacts are in quarantine. So that's the fundamentals of a rapid response. Thanks.
Thank you, Hassan. Then Prof. Lipsitch, just coming back to you, there was a question linked to children and infection in children, and a question linked to when one says children do not transmit, and bearing in mind the debates on opening schools, which age group are we talking about?
Yeah, so thank you. I would not want to take strongly the position that children don't transmit. I think that is the view of the RIVM in the Netherlands, and I think they have some data to support that view. I know other colleagues who think it's quite clearly the other way, based also on quite limited data. I think the discussion is mainly about young children. Under 14 or so. The RIVM data go up to 19, but other data have suggested that adolescents and young adults are significant transmitters. So I think the data are pretty terrible right now, and that the range of opinions reflects people's priors and sort of how much they weight data from other illnesses, other infections, and the like. So I think it's reasonable to have almost every view at this point, and I fear that the best way we're going to find out the answer is to open some schools in some places, which is happening, and watch what happens if there's adequate surveillance in place to try to understand how much is traceable to those schools. But I think it's a really, really, really challenging area right now.
Thanks for that comment. And I think taking into consideration the big challenging times that we're in, and all the challenges that's been highlighted during the 2 presentations, I think one of the questions that I have is what can be done to address these issues. And one of the questions that's been posed in the chat is, based on lessons in terms that we learn, what are the lessons in terms of the future of teaching and learning of epidemiology and public health, given the COVID-19 pandemic, and how could higher education institutions respond to address some of these challenges?
It's Hassan. I can have a shot at that.
Go ahead, Hassan.
Yeah. Look, I think, again, getting people to understand methodology is important, how data is collected, what the data means, encouraging critical thinking. Everyone should learn about bias and confounding and how that might affect routine data. I mean, I saw a question in the chat there, what data can we trust, if any? And I mean, I could say none and, you know, end it off there, but that's really was not the intention. The intention is to think about data that's presented to you, ask questions, where does it come from, how was it collected, what are the potential biases, meaning, you know, is there an underestimation, is there an overestimation? You could even ask questions like, what's the agenda behind the person producing the data? So I think developing these kinds of skills is where higher education institutions can play a role, building this culture of critical thinking, but not, and I think the intention there is not to create an ethos of dismissiveness. You know, I mean, I think it's really just to for people to understand how decision making can be best supported using data or other means in order to assist with how strategies are developed, how decisions are made, how does one actually effectively contain an epidemic, and what sort of data would be best to use. I mean, I think there's no getting away from the fact that this is a new epidemic. We've all caught a bit by surprise by it. There's a lot that we're learning virtually every week. But also what's useful to also see is that the huge amount of publications that are coming out, the huge amount of attempts to actually try and understand it and to help us make good decisions. So higher education institutions can perhaps assist with getting people to do good research, trying to do it quickly, and also trying to compile this research into meaningful summaries, policy briefs to help decision makers who have to make perhaps sometimes quite difficult decisions. Thanks.
Thanks. I think everything that was just said is absolutely right. I would add, I put in the chat box something that I wrote on sort of related issues in the Boston Review. And I think what Hassan said about we can't just say don't trust any data is absolutely right. Of course, if we don't trust data at all, then we can't make any sort of sensible decisions. And I think really the way to think of it is that epidemic data is generated by human systems and very fast changing human systems that are changing at the same rate that the data generating process, the epidemic, is changing. So testing is scaling as cases are changing. And I think the piece that's been really remarkable to me is that in many quantitative fields like physics, economics, chemistry, there are a lot of very smart people, computer science, who are trying to contribute to the analysis of this epidemic. And what I think only a few of those people understand, and those are the ones who make the best contributions, is that in their world, you know the precision of your instrument. It's the same instrument that was used yesterday and a year ago. You know the problems. If you're measuring unemployment as an economist, you know that unemployment doesn't capture certain things, but it was the same people, it was the same problem last year as it was this year. And what needs to be understood is the data generating process as best we can. And I think both talks sort of tried to get to that. And so the trick is to intersect really good quantitative methods with a really good understanding of what the data generating process is, so that you don't do the sensible thing in other fields, which is to fit to data as if it was always the same, but rather focus a lot more on how it's generated, what the sensitivity and specificity are, how that matters in some cases and doesn't matter in others. All these epidemiological concepts. So it's really a matter of bringing the disciplines together between the quantitative and the sort of how does the data come to light disciplines.
Thank you. Thanks for that comment. And I'm keeping my eye on the time, and I think we've covered a very comprehensive session where we've looked at the variety of concepts linked to the pandemic and epidemiological measures. I think it was really great to have a reminder of various epidemiological concepts and aspects to consider in how to interpret and how to use data, and also all the various influences of that data. And it's great that we looked in at a bit around what higher education institutions can do to see how we can prepare the next generation to be able to advance and enhance what we do linked to epidemiological data. So I want to take a moment just to thank our three speakers. Thank you very much for your input and the time and for being available to join us. It was really valuable. We've made a recording of the session, and we also have the presentations available. So thank you for everybody who has taken the time out to join us for the session. And just as a reminder that our next webinar will be on the 18th of June. So thank you very much to everyone who joined, and again to the speakers, and enjoy the rest of your day. Thank you and goodbye.
Thank you, Taryn.
Thank you.
Thanks, everybody.
Thank you.